Welcome to the symposium entitled Falls in Lower to Middle Income Countries, an Update. This symposium was conceived by the writing group for the World Falls Guidelines, the developing country group. And in order to actually write the bits for developing countries, if you like, we needed to actually scope available literature published by people working in developing countries, either people from developing countries themselves working in their home countries, or those from developed countries who actually conducted these research in the developing countries. And clear themes emerged when we did this scoping exercise, and it was very clear that we had a lot of information. There was no longer a dearth of information on falls in developing countries. In fact, there is actually a wealth of information, even though it's all being dwarfed by information available from developed countries. It is therefore very important, we felt, that we share this information with all of you, so that if you were considering, if you're working in a developing country, that you would actually be able to make use of this information to lobby for resources, to develop your own guidelines. And also, if you were from a developed country, that whenever you write a paper, do any research, you should actually consider this information from developing countries, and if possible, also include developing countries in your multi-center research. So we've broken the symposium into three topics, and the first topic will be presented by Dr. Fernando Gomez, or Professor Fernando Gomez, who is actually the director of the Geriatric Medicine section of the Faculty of Health Sciences at Universidad de Caldas, Manizales, Colombia. He's a past president of the Colombian Association of Gerontology and Geriatrics and a council member of the IAGG from 1996 to 2016. And he has published widely on the topics of sarcopenia and falls, as well as other topics related to aging and geriatric medicine. So Professor Fernando Gomez is going to bring us a talk on risk factors for falls in lower middle income countries.
Good morning. Thank you for joining us at this symposium. This is my first presentation about risk factors for falls in lower middle income countries. My name is Fernando Gomez. I'm director of geriatric medicine section in Universidad de Caldas, Manizales, Colombia. We are here on behalf of World Falls Guidelines Development Group. These are my outlines. First, show the general results, then risk factors for fall in developing countries, show the high-risk groups identified in our research, several comments about environmental hazards, the vision and hearing risk factors, and finally show the knowledge gaps on research and conclusions. Our group come from the global guidelines for fall in older adults that help 12 groups involved to find the best evidence about falls in different topics and areas, and we are the group in falls in developing countries. As you can see in your left, there are a lot of publications and papers in recent years with increase in the last year, and in your right you can see the production by countries, with Brazil at the top, followed by China, Thailand, India, Iran, and Malaysia. And the general prevalence of falls is 23.8%. And 21% report consequence of falls. The most common fractures, followed by mortality as consequence of hip fracture, fear of falling, hospital admission, institutionalization, healthcare costs, brain injury, and pain and breathing and disability. When you talk about risk factors for falling lower middle incomes, you have the need to involve interactions in two situations. First, multimorbidity. At least 50% of people over 65 years old have morbidity, multimorbidity. And the other thing is the increase of multimorbidity in developing countries. And the second situation is the accumulated effects of age-related impairments in multiple systems. For example, vision impairment is 4 times higher in developing countries compared with high-income countries, with many problems as unaddressed refractive problems, cataracts, macular degeneration, and glaucoma. And when you talk about risk factors, several risk factors are consistently identified in longitudinal studies in developing countries, similar to high risk, to high income countries as polypharmacia, previous falls, dizziness, poor muscle strength, and gait and balance impairment. There are another risk factors related with low cognition, with particular characteristics in our region, as low cognition, for example, is related with low educational level and poor socioeconomic status, especially in women. Multimorbidities as osteoarthritis, diabetes, cardiovascular disease, including stroke, osteoporosis as a risk factor for fractures, neurodegenerative disorders, for example, Parkinson's disease, and several geriatric conditions as frailty, sarcopenia, and urinary incontinence. The vision and heavy sensory impairment that I said, and another interesting risk factor for our region is the inappropriate footwear. And later I talk about the characteristic of environmental hazards in developing countries. Especially the inappropriate footwear, especially in tropical climates, is an important risk factor because the barefoot is very common in these regions. We are identifying high-risk groups for falling in developing countries. First, the group over 80s, women, the rural areas, depression, poor cognition, and multimorbidity. As you can see, there are 2 non-modifiable factors. There are 2 factors related with mental health and 1 condition related with chronic conditions. And it's very important to say here about the elderly in rural areas, because it's an important group for falling, because the difficulties of geographical condition, especially for mobilization. Respect at environmental factors are predisposing conditions for fall-related injuries, and studies in developing countries show an increased risk of falls due to environmental factors. That is the relationship with environmental and individual conditions, and we need more research about the relationship between the environment, individual and fear of falling as risk for fall, the falling and outdoor mobility, especially in rural areas where poor quality footpaths and unsafe walking areas is the rule in our countries. And the other situation in the means for outdoor mobilization that we need to research in the future about the means for mobilization in rural areas. Two aspects related with environmental hazard. First, the home hazard identified in developing countries as absence of handrail and poor lighting in stairways, lack of electricity, and one problem very common in rural areas, the toilet or bathroom outside the house, the slippery floors, and the absence of grab bars in latrines in rural areas. And the other thing is the environmental hazards with two situations. First, neighborhood with physical disorders as presence of trash and litter on the street and sidewalks, the cracked pavements and poor lighting, and unsafe neighborhoods with higher rates of violence that might lead older people to avoid leaving their house, restricting mobility and social activities, and as consequence, the conditioning, isolation, and depression. As you can see, the condition of the stairs in rural areas is a difficulty for elderly people. Regarding vision and hearing, we recommended at least annual assessment and treatment of their vision and hearing, because sensory impairment is a prominent risk factor for falls in this population, and it's very important to identify and promote programs for unaddressed refractive problems in our countries. Finally, the knowledge gaps on research. Now is evident the increase of research on risk factors in developing countries, but we have limited evidence available about low cognition and the role of the cognitive reserve and falling in our countries, about nutritional deficiencies, the role of obesity, and as I say, the lack of appropriate footwear in elderly people. And our recommendation is in developing countries should produce more good quality research on this factor specifically and on falls in general. As conclusion, first, many of the risk factors for fall in developing countries are similar with high-income countries. Second, however, others are associated to cultural and geographical characteristics of the countries. We need more for cultural and environmental specific interventions. And finally, many knowledge gaps about fall risk factors should be clarified in the coming years. Thank you.
So next up, we actually have Professor Monica Paracchini, and she is professor at the master's and doctoral programs in physical therapy at Universidad Cidade de Sao Paulo. I hope I said that right. And at the master's doctoral program in gerontology at Universidad Estadual de Campinas, Sao Paulo, Brazil. Are actually going to bring us a talk on psychological issues and falls in lower to middle income countries.
Hello everyone, I'm Monica Peracini from Brazil, and it's a great pleasure to present in this symposium during the IAGG Congress. In this presentation, I will address psychological issues and their relationship with falls, and particularly what are the challenges of implementing routine assessment and treatment of depression for falls prevention in low and middle income countries. First, I would like to acknowledge the contribution of Renato Barbosa Santos and other key collaborators from the Working Group on Falls Prevention in Developing Countries that are members of the Global Guidelines for Falls in Older Adults. Well, is there a relationship between psychological issues and falls? For example, can we presume that being depressed increases the likelihood of experiencing a fall? A recent systematic review and meta-analysis showed that 11 of the 18 included studies found that depressive symptoms caused a subsequent increase in falls. Also, 6 studies showed that depressive symptoms are also predictors of future falls. However, the meta-analysis only supported the association between fear of falling and falls. Authors have suggested that a complex relationship exists between depression, untreated depression, antidepressants, fear of falling, and falls. For instance, depression-associated symptoms such as slow gait, particularly during dual task, slow cognitive processing, and decreased psychomotor responses can increase the risk of falling and are also present in older people with fear of falling. In the opposite direction, falls and fear of falling can also lead to poor self-efficacy and dependence, and also increase the likelihood of depression. However, the specific mechanism of this complex relationship between depression, depressive symptoms, use of antidepressants, fear of falling, and falls are not entirely clarified yet. Well, what are the scenarios for depressive symptoms or depression as a risk factor for falls in low and middle income countries? Our systematic review retrieved 11 studies conducted in low and middle income countries that also support that there is association between depression or depressive symptoms and falls. For instance, in Iran, the risk of future falls were 3 times higher among older women with depression. And in Brazil, a population-based study of community-dwelling older adults with positive screening for depression, measured by the Geriatric Depression Scale, had an odd of 2 times for reporting a recurrent fall in the previous year compared of those with a negative screening. Nevertheless, could we assume that psychological risk factors for falls are different between older people living in high-income countries and low- and middle-income countries? Well, if we assume only a biological perspective at an individual level, this difference might hardly exist. However, suppose we assume a social ecological model in which there is a multi-level interplay of factors that can influence psychological issues and falls. In that case, we must acknowledge that differences might also be driven by differences at, for instance, the community level, such as the presence of deprived neighborhoods and violence and lack of social and healthcare policies, for the management of mental health problems among vulnerable older people that might influence how this population perceive and experience depression. It has been recognized that a narrow framework for preventive measures could lead to inappropriate practices and fragmented and non-person-centered interventions. I want to underline some possible challenges for screening, assessing, and managing depression as a risk factor for falls in low and middle income countries. Well, how to screen and assess depression or the presence of depressive symptoms? There are current WHO guidelines for managing depression. One of them is MGAP guideline, that is targeted to professionals in no specialized care settings to help them identify and treat depression in the community. And also the ICOPE, that was developed for implementing integrated care for older people based on domains of intrinsic capacity. Both of these guidelines present a pathway of care for managing depression and offer in this pathway of care instruments, measures, and also simple questions for screening and also assessing depression. There are also frequently used scales to assess depression or screen depression, such as the Geriatric Depression Scale and the CESD, the Center of Epidemiological Studies Depression, that also can be used for this purpose. However, considering the socio-ecological model, it's reasonable to think that low and middle income countries face many challenges when implementing these guidelines. For assessment, we can consider, for instance, at the individual level, factors such as few years of schooling, health illiteracy, and at the organizational level, the failure of health organizations to train primary care physicians and care workers to identify other people with depression. Furthermore, on a society level, for instance, the presence of ageism and stigma about mental health issues might impact how older people view themselves and how they receive the care they need when being depressed. So, poor screening and assessment might result in untreated depression and increased fall risk. Low and middle income countries must set up strategies to overcome barriers for implementing depression assessment, not only in primary care, but also across the continuum of care, including older people in long-term care, such as people living in long-term care facilities or attending daycare centers. Also, we can list several factors in management of depression, such as poor adherence to the proper use of antidepressants due to accepting depression as a normal aspect of aging, and also the high cost of these medications and the lack of a multidisciplinary care team to deal with this poor adherence. Furthermore, non-pharmacological interventions such as cognitive behavioral therapy and physical activity are less disseminated among professionals in low and middle income countries to manage depression. Well, there are several possible implications of not identifying and managing depression and its correlates for implementing fall prevention strategies in low and middle income countries. For instance, our clinical trial study in Brazil revealed that 55% of older people reported physical problems as a reason for not attending the program, and of them, nearly half reported fear of falling, and around 20% had a positive screening for depression using the geriatric depression scale. We also identified that a positive screening for depression was independently associated with the inability to get up from the floor after a fall, adjusting for cover rates, and unrecovered falls represented nearly 52% of the cases. Finally, it's essential to say that depression should be considered when evaluating the risk of falling in older people living in low and middle income countries. However, there is a lack of evidence and more high-quality research is needed, for instance, to identify if older adults not adequately treated for depression are at higher risk of falls, and also investigate barriers for implementing pharmacological and non-pharmacological interventions to manage depression, such as what are the preferences, what are the values that are surrounding older people in middle-income countries, and particularly what are the circumstances of managing depression in primary healthcare settings in these countries. I would like to thank you for your attention and leave here my contact details, and also acknowledge my other collaborators in Brazil from the Previqueda's Brazil Research Group.
And the final presentation will be brought to you by Devinder Kaur Ajit Singh, and she's the professor and chair for the Center for Healthy Aging and Wellness at the Faculty of Health Sciences, University Kebangsaan, Malaysia. She's a qualified physiotherapy and has gained prominence as a pioneer in geriatric physiotherapy and produced numerous articles defining the practice of physiotherapy in this field in Malaysia. And they are going to bring you a talk on gait and balance assessments for falls in lower to middle income countries.
Hello, greetings from Malaysia. I'm Devinder from Center of Healthy Aging and Wellness, Faculty of Health Science, University Kebangsaan, Malaysia. On behalf of the World Falls Guidelines Development Group, Lower and Middle Income Countries Working Group, I would like to present Gait and Balance Assessment for Falls in Lower to Middle Income Countries. It is well established that falls occur due to a mismatch between an individual's physiological function, environmental requirements, and individual's behavior. This brings us to the fact that falls in older person is as a result of interaction of multiple risk factors. Risk assessment is a common practice in medicine and health sciences, whereby all known relevant risk factors are taken into account of a person's probability to experience a particular condition. Hence, ladies and gentlemen, falls risk assessment is a key component of falls prevention. It is also important for identification of those most at risk of falls to prioritize further management. It's noteworthy that one of the leading fall risk factor is gait and balance impairments. Thus, in most falls prevention guidelines, gait and balance assessment have been recommended for older people with risk of falls. However, there's paucity if globally recommended physical assessment tools for gait and balance impairments are applicable in low to middle income countries. We reviewed literature regarding The best physical assessment tool for gait and balance impairment among older persons in low to middle income countries. Based on the literature review, 978 studies were located, out of which 38 studies use gait and balance assessment tools. Out of these, 38, 14 use time up and go tests, 10 use Berg balance test, 7 use dynamic gait index, dual task, and tandem walk. The other tests were functional reach test, senior fitness test, chair stand test, short physical performance battery, and abs related tests. Mostly evidence were from Brazil, with other countries having only 1 to 3 related studies, which included Thailand, Chile, Malaysia, China, India, Iran, Nepal, Pakistan, and Turkey. Our results showed that there was no single physical assessment tool that could be used to perform a risk assessment for gait and balance impairments in relation to falls risk. Also, information on predictive validity of the tests for differentiating high and low fall risk is not available. From our own local experience, time up and go tests combined with self-rated multifactorial questionnaire on falls risk and socio-demographic factors predicts falls among community dwelling older adults better than the TUG or time up and go test on its own. In addition, muscle strength appeared as a stronger risk factor and predictor compared to balance in younger older persons in Malaysia. While there is lack of firm evidence to best single physical assessment tool to be used for assessment of gait and balance impairment among older adults with risk of falls in lower to middle income countries, time up and go or muscle strength tests may be used with reference to the normative data or cutoff points established for the population if available. Time up and go test was initially designed to assess mobility. It is a simple to perform and feasible as minimal equipment and space, duration is required for it to be carried out. In one of our local studies, we found that only TUG in comparison to gait speed and walk while you talk illustrated a significant difference in mean score between older persons with and without incidence of falls. Time up and go test has a few components that includes sit to stand, walking and turning. That could have been the reason for appearing as the apt tool for falls risk when compared to gait speed and walk while you talk. While lower limb muscle strength test mimics activities of daily living, and increased lower muscle strength is beneficial in preventing falls in older persons. On the other hand grip test needs a hand dynamometer and is used to assess hand muscle strength. Hand grip test has been reported to be correlated to general body muscle strength. Recently, gait speed was recommended as an assessment tool for gait and balance impairments for falls prediction in the higher income countries. Given its low cost and ease of administration, it may be a useful tool to implement in low to middle income countries. However, the limitations of performing gait speed is space. Space is required to perform this test, and in many lower to middle income countries, this is not feasible or possible when conducted at community centers. Also, there is no standardization for its protocol with varied distance used so far. Also, for its timing commencement, it may vary based on moving start, or a static start. As conclusion, a routine assessment of gait and balance performance should be part of a holistic multifactorial fall risk assessment in older people deemed to be at high risk of falls. Time up and go, hand grip test, or sit to stand test may be used as an initial screening tool for falls risk in older adults in low to middle income countries. Further assessment should be performed using comprehensive tools to identify specific impairment for personalized intervention. In addition, studies on the validity of the test as a falls risk assessment for gait and balance impairment in older adults is required in low to middle income countries. With that, I would like to thank you.
So now it's time for questions. So please do ask us lots and lots of questions through whatever mode that's provided to you and convenient to you, and we will try our best to provide the correct and accurate answers. Thank you very much for coming to our symposium. Hi everyone. Oops, I think 10-second delay. Yeah. Hi everyone.
Hi.
Hi. Thank you for joining us for joining our session, and we've got a little bit of time to do some discussions. I have some questions for our panelists today. So the first question, maybe we start with Professor Fernando Gomez from Colombia. Could I ask, obviously we're working together to actually develop, help representing developing countries in contributing towards the World Falls Guidelines, which are ongoing and hopefully will be released this year. Could you maybe share with people who have attended these sessions the challenges we have had in actually developing guidelines specifically for developing countries?
That is a very difficult to say for developing countries as high income countries to develop guidelines, tactic guidelines to identify high risk groups. That is very difficult for many reasons, because the geographical aspects of our population come from rural areas, come from urban areas, suburban areas, and the real problem to identify and to follow a specific guide as is identified in developed countries is the socioeconomical conditions. For example, for us is the guidelines for falls say about please treat vision problems, and for us in all rural areas the vision problem most important is the addressed refractive problems. For the developed countries, that is cataract, that is another condition. But for us, the first problem is unaddressed refractive problems, and the socioeconomical conditions are a real barrier to identify high risk and follow guidelines about falls. But the idea is continue the research about the differences geographical and cultural for these guidelines.
Monica, do you have anything to add to what Fernando had to say?
Well, I think first of all, it's important for us to say that having this working group within the World Falls Guideline is very encouraging for us, because we do need some more information and more discussion around falls in low and middle income countries. In fact, we all know that the majority of older people is going to be living in low and middle income countries in the future decades. So it's an urgent call to action for us to have, some guide on how to deal with falls in our countries. But I totally agree with Fernando, because we have a very variable scenario in our countries, not just in the rural or remote areas, but in urban areas. As for instance, in Brazil, we have very vulnerable populations living in the private neighborhoods and in slums. So we don't not know at all if this population is going to be at higher risk of falling due to, for instance, we believe that they are in a higher risk for falls due to socioeconomic issues and also environmental problems. But the lack of research in this regard, it's appealing, and we do not need more research in our countries to not only know a little bit more on these vulnerable populations and risk for factors for falls, but how to manage and how to prevent these falls among this population. So having this working group is very promising.
And it's probably one of the first guidelines that's specifically considered a working group for developing countries. But maybe I should address the next question to Dr. Sumaya. Dr. Sumaya is representing the University Kebangsaan Malaysia on behalf of Prof. Devinda, who, because of the time difference, can't join us this morning because it's now 12:45 a.m. in Malaysia. And Maya, with regards to trying to contribute to these guidelines, perhaps you could share with the audience what kind of challenges we have had, because obviously we are drowned in evidence when it comes to falls, but then only a small part of the evidence actually comes from developing countries. So how do we then apply this huge imbalance? How do we actually make whatever research that's been done in developing countries apply to the World Falls Guidelines?
Thank you, Professor. I think, as we all aware that lower and middle income countries represent measures of the worldwide population. So I think it is really important to provide a guideline that represents LMIC that can stand alone, which I think is difficult and it's take a lot of work because of we know that there is huge amount of study coming from LMIC, but then the study is very variety in terms of the quality, and also the evidence is also mixed. Yeah. So there is important to like consensus to come up with a guidelines that can provide proper information for future study. What should we focus on this, the gap in the knowledge, on the false issue around the LMICs, and also it is important to get all the experts in falls coming from the LMIC together to really brainstorm and come up with the guidelines, because we are the one who are living in the LMIC and we know the actual, the reality in LMIC, especially the multicultural issues. It's not just the demographic and also the socioeconomical status. It's also the cultural issue, especially like Malaysia. We are multiracial, so we need to address all these issues as well. Yeah, I think that's the things.
We're going to pause for a while. We're going to pause for a while from this discussion about the World Falls Guidelines, because we've got a couple of questions from the audience. So from Shaser Marcus, how to leave theory and bring it to practice in relation to programs to prevent falls. I think that's a challenge we all have in developing countries. Perhaps, Monica, would you like to start off answering that?
Yeah, sure. Well, I think first of all, we need more implementation science research in low and middle income countries. And I saw this movement of implementation science coming for our countries, and it's very important because we do need to know what are the barriers and the facilitators for implementing falls prevention program. We can just bring this information from high income countries and try to push them forward in the health system. So we really need to understand what is happening on our health systems. And, there are different contexts. Even in Brazil, we have differences in states, for example. And so it's very important for us to have these local research groups acting on behalf of understanding, what are the challenges for implementing. But we have to start anyway, because otherwise we are going to lose our time, just complaining about how to implement this evidence. But we should start. For instance, we probably is going to make some mistakes, but it's not a problem. The problem is that we have to do something. And also we need more policies, around this in low and middle income countries as well. So we have to convince policymakers that this is a real problem and it's going to strike us in a very short period of time. So we need to have more, implementation research, and also we have to have more discussion with the health care workers in organizations and all the stakeholders to have, for instance, a policy implementation program in our countries. Definitely, yeah.
Yeah, and we hope that with the World Falls Guidelines, it gives us ammunition to actually present to our policymakers to push this forward, isn't it? Yeah. Fernando, you talked about lots of risk factors, but Shimunis Eduardo actually asked, what about environments related to risk of falls? I think you showed a really interesting uphill gravelly pavement. Perhaps you would like to expand on this?
Yes, I want to add several barriers very common in our countries, independent the region. But the problem is low level education. That is very important. Being women, because the machines continues and don't permit too many programs for women, especially in rural areas, inequalities, religion process, and the problem to identify clearly the responsibility of each person about to prevent falls. And the other is the health system, as Monica said, and other condition is poor conditions and hungry. Because why? That is the reason why in our group say the nutritional deficiencies are a very important risk factor for falling. That is different, multicultural. Yes, that is and I think that we need to approach a different approach from our region comparative with income countries.
Quite agree with that, Fernando. Right, Siripan Sasat actually, hi Siripan, would actually like to know whether there are any different in false risks between community and institution and between urban and rural areas in LMICs. Maybe Maya, would you be able to expand a bit on that?
Sure. So, of course, there are big difference in between risk factor in institutionalized population and community dwelling. Usually, the community dwelling are healthier as compared to the institutionalized older people. And of course, the environment also play an important role, because we know that community dwelling are more freely, more mobile as compared to institutional. So they are exposed to different type of home hazard or environmental hazard as compared to the institutionalized older people. Yeah.
And Monica, maybe could you address the urban-rural difference? Have you noticed anything with Brazil, for instance, with differences between urban and rural risks of falls?
Well, we don't have many research on that, but during our systematic review, we are able to retrieve some information around environmental factors, such as, for instance, South Africa, we have the toilet outside the home, so people have to get up and, for instance, at night and go out to use the bathroom. So, yeah, there are some problems around, cracked pavements in urban areas in low and middle income countries, and also some problems with furniture, furniture that is not strong or, enough to support the weight of older people, for instance, when you are getting up from a chair or something like that. So there are some big issues around environmental factors in low and middle income countries, but we do need some more information around it, but there are some difficulties because research on environmental factors are not easy to conduct. For instance, in Brazil, we had one of our students conducted I study with environmental factors, but asking older people to evaluate their homes. So they give some instruments for them to check out environmental risk factors, and then they had their house checked by healthcare professionals, and there is a huge difference. They are not able to identify correctly the risk factors. So we did need some more investigation how we can tackle this problem, around environmental factors, and how we can easily manage that, because it's not easy for us to check all the homes, for people who is at risk of falling. So we do need more information around that.
And that leads us nicely to, sorry, Fernando. We just have about 4 minutes left, so I thought I could just introduce the last question, which is quite relevant to what Monica just said. So we're so behind in developing the evidence for developing countries. We can't really repeat everything the West have done in order the developed countries have done in order to redress the balance. So how best should we actually target our research efforts in order to basically make the best contribution towards enhancing research evidence in developing countries? Maybe Fernando, you would like to take this first?
Yeah, I first, for this situation, the difference between developed and undeveloping countries is social participation and the family, and we need more programs added the family and the family nets, friends net, and social participation is our most important opportunity to develop falling prevention programs.
Quite agree, Fernando. Maya, what do you think? How should we actually put together evidence for lower middle income countries to make it really matter in a very short period of time?
I think that is always the high countries say about and insist in the evidence, and for us the evidence is important. But there are different characteristics about our programs for prevention falls, for prevent depression. We need a regional and cultural perspective for the situation. And I think that is the possibility to identify an evidence very strong for our programs. But we need develop evidence, but slow, and with a geographical and multicultural approach.
I
Maya?
agree with Prof. Fernando, yes. For me, I think the shortest strategy is to develop a multi-center study, multi-site study around the LMIC. So each all the country can take part in the study and give feedback on their cultural and also their demographical differences, in how they influence the risk factors of falls. Yeah.
And Monica, do you have anything to add?
No, I have to agree totally with both of you that we do need more collaboration, I think, in conducting research in low and middle income countries. We are very underfunded for research in low and middle income countries. This is one, I think, huge problem, at least in Brazil. And so that's a problem. So we need more research collaboration around us, to not just to search funding abroad, perhaps, or have different sources of funding, and then try to understand what are, as Fernando said, the cultural differences and the values, and really want to know from the perspective of the older person, the family, and the healthcare workers, what are the main issues in our countries to be addressed to prevent falls.
Yeah. And there's this obsession with the strength of the evidence, but if we always emphasize on strength of the evidence rather than the relative importance of the evidence, developing countries will always miss out. Yeah. So thank you very much, everyone. I think we're out of time, and goodbye.